Good afternoon. We will now begin today's webinar. This webinar is part of the Direct Care Workforce Strategies Center National Webinar Series. Today's webinar is titled, Addressing the Shortage, the Current State of the Direct Care Workforce. Before we begin, we'd like to review some important housekeeping items. All participants have cameras turned off and are muted. Participants may submit questions via the Q&A feature. If time allows, we will have a brief Q&A at the end of today's session. We also have ASL interpretation and CART available. CART can be accessed within Zoom or using the link in the chat to open in a separate window. Spanish translation via CART is also available through the link. To access CART in Zoom, attendees will need to select the Show Captions button on the bottom toolbar. This will cause the button to change and now read Hide Captions. Click on the caret next to the Closed Captioning button. In the menu, make sure Translation toggle is turned off and make sure that the My Caption language is set to manual captioning. Please reach out to conference@ncoa.org should you have any technical issues during the webinar. This webinar is being recorded and a copy of the slides will be available after the webinar on the ACL website. We are also excited to announce that HHS has announced the TA Center's selections for the intensive TA states and the advisory committee for the center. One of my colleagues will put a link in the chat to that announcement. I would now like to introduce today's speakers. Today we are joined by our Bipartisan Policy Center colleagues, Lisa Haratunian, Director of Health for Bipartisan Policy Center's Health Program, and Allison Buffett, Senior Policy Analyst for the Bipartisan Policy Center's Health Program. First, they will be presenting on the Bipartisan Policy Center's recent work on addressing the direct care workforce shortage. Next, we will hear from a panel of other national experts, moderated by Stephanie Gibbs, Director of the Direct Care Workforce Strategies Center at the National Council on Aging. She will be joined by Tony Gingerelli, Associate Director of Policy and Advocacy at the National Alliance for Caregiving, and Kezia Scales, Vice President of Research and Evaluation at PHI. I now turn it over to Lisa and Allison to begin today's program.
Thank you. And hello, everyone. My name is Lisa Haratunian, and I'm a director for the health program at the Bipartisan Policy Center. I want to first provide a physical description of myself for any viewers with visual impairment. I am an Armenian woman in my 30s with blonde colored hair and brown eyes, wearing a white blouse and a blazer. I'm also here with my colleague, Allison Buffett, who will join me in presenting to you on the direct care workforce. She will introduce herself when I hand off during the presentation. Next slide, please. First, I will provide an overview of the Bipartisan Policy Center and what we do. Second, we'll talk about the direct care workforce, including who these professionals are and the challenges that have contributed to this workforce shortage. Third, we'll explore some options for reforms that can be implemented at the federal and state levels. And then fourth and finally, we'll transition to a panel discussion to explore some of these topics in more depth. Next slide, please. So let's get into it. I'll tell you about BPC to provide some context for the work that we have done to identify challenges that contribute to the workforce shortage, as well as develop some options for those policy reforms. Next slide, please. So what is the Bipartisan Policy Center, also known as the BPC? Well, we are a nonprofit, Washington, D.C. based policy think tank focused on bipartisanship and durable, feasible policy solutions. We were founded in 2007 by 4 former Senate Majority Leaders, including Senators Howard Baker, Tom Daschle, Bob Dole, and George Mitchell. We have programs in several areas, including health, immigration, housing, the economy, and several other programs. Next slide, please. Speaking now about the health program specifically, the health program's leaders include former Senate Majority Leaders Tom Daschle and Bill Frist. And when we approach policy issues, such as the direct care workforce shortage, we work with Republicans and Democrats to develop viable bipartisan policy solutions. We convene stakeholders and policy experts from across the aisle to explore these issues and potential policy reforms, all with the goals of achieving a high-value, equitable, and accessible healthcare system. We also have a partner organization, a 501c4 organization known as BPC Action, and they help with disseminating our findings among federal policymakers. Next slide, please. Now that you know more about the BPC, I want to tell you about our research and our findings on the direct care workforce shortage. We released a report in December 2023 on this topic, and it's available on our website at bipartisanpolicy.org if you want to learn more. Next slide, please. So now let's start with some level setting and terminology. The term direct care workforce is a broad term that includes a range of direct care occupations that all use many different titles. One thing these occupations all have in common, however, is that they generally include individuals who assist older adults and individuals with disabilities with essential daily tasks and activities, such as getting out of bed, bathing, or medication management. These occupations also work across long-term care settings, including in private homes, in community-based residential care settings, such as an assisted living community, in skilled nursing homes, hospitals, or other settings. And given the range of occupations or job titles that fall under this umbrella of direct care professional, the training requirements also vary significantly by specific occupation and by state regulation. It's also notable that there is a large gray market of home care workers, and this refers to individuals who are hired directly by individuals using private funds. Now, BPC's work, which we will refer to throughout this presentation, is primarily focused on personal care aides, home health aides, direct support professionals, certified nursing assistants, psychiatric aides, and unpaid caregivers. And I want to note that almost 50 million unpaid caregivers do play a very critical role in alleviating demand for paid direct care professionals. And one estimate finds that the economic value of this care is about $600 billion. Next slide, please. Now that we know more about this workforce, let's talk about the urgent need for more of these professionals. There has been this long-standing shortage of direct care professionals in the US for over 2 decades, and it was recently exacerbated by the COVID-19 pandemic. This shortage is due in part to rising demand from an increasing number of older adults as the baby boomer population ages into retirement. Another contributing factor is increasing life expectancy, which means that the older adult population is not only expanding, but this population will also need care for a longer period of time than previous generations. And while the COVID pandemic exacerbated this workforce shortage, it did also highlight the essential contributions of this workforce. And despite the rising demand for care, we have a direct care workforce that's only grown from 3 million to 4.6 million between 2009 and 2019, and experts are anticipating significant workforce gaps going forward. And while we know there is a shortage of direct care professionals that Americans are feeling every single day, there is no national estimate of the size of this workforce shortage due to data limitations. And my colleague will talk more about this challenge later in the presentation. However, it is notable that demand for direct care professionals is likely somewhat greater in rural versus urban counties, and there is increasing demand in home and community-based settings as well. Next slide, please. We've talked about the state of this workforce shortage, so now let's talk about the impacts. It's important to address this workforce shortage because it's straining the healthcare system and it's harming care access, quality, and costs. In 2021, there were 656,000 individuals on waiting lists for Medicaid home and community-based services. And some research suggests that these long waiting lists might be partially due to the shortage of direct care professionals. This workforce shortage is also contributing to providers such as nursing homes or home health agencies not being able to accept referred patients due to staffing shortages, and in some cases, closing. For example, in a 2024 survey of nursing homes, almost half reported that they had had to turn away a referred patient due to staffing shortages. Lastly, not having enough direct care professionals to meet this rising demand for care is limiting access to long-term services and supports, which have the potential to reduce avoidable hospitalizations and costs. Next slide, please. I also want to underscore the importance of addressing this workforce shortage from an equity perspective. As you'll see on this slide, the direct care workforce is predominantly and disproportionately comprised of people of color, immigrants, and women. Uplifting this workforce and making these occupations better, more desirable roles is really crucial to promoting gender and racial equity. Next slide, please. Now that I've provided some background on who these workers are, the state of the shortage, and the importance of addressing it, I want to turn it over to my colleague, Allison Buffett, to talk with you about the specific challenges contributing to this workforce shortage.
Thank you, Lisa. Hi, everyone. My name is Allison Buffett. I'm a Caucasian white woman with straight blonde hair, wearing a purple shirt with a black blazer. I'm a senior policy analyst at the Bipartisan Policy Center. I'm going to walk us through the key challenges and potential opportunities for addressing the shortage. Let's start with the challenges. Through BPC's research, we identified 3 key challenges contributing to the shortage. The first challenge is that there is inadequate support for direct care professionals. This impacts both recruiting people to join the workforce, as well as retaining direct care professionals currently in the workforce. The second challenge is that there is inadequate data on the workforce. This hampers policymakers' ability to understand and tackle the shortage effectively. And the third challenge is that the nation's workforce programs are often not targeted towards direct care professions. This limits the growth of the workforce. In these next slides, I'll walk us through each of these challenges in more detail. Next slide, please. Let's take a look first at the challenges contributing to the workforce shortage, which is that direct care professionals often have inadequate support, such as low compensation. Most direct care professionals are underpaid. For example, in 2022, the median pay for home health and personal care aides was $14.50 per hour, or around $30,000 a year total. This compensation is not competitive with other jobs that have similar entry-level requirements. As we think about ensuring adequate compensation for direct care professionals, we need to understand who is paying for these long-term services and supports, otherwise known as LTSS. Some people pay for these services through private out-of-pocket payments. Additionally, Medicare covers a limited amount of LTSS in certain circumstances. I think it's really important to understand that Medicaid is the primary payer for long-term services and supports. These Medicaid provider payments play a role in ensuring support for direct care professionals. Employers of direct care professionals, such as home health agencies, also play a role in determining compensation. They often determine compensation based on the payment that they receive, the cost of giving these services, and the cost of operating their agencies. In addition to low wages, many direct care professionals also lack access to essential benefits, such as healthcare or retirement plans. Another challenge contributing to the inadequate support for direct care professionals is that there is a lack of consistent, portable training and career advancement opportunities. For example, the majority of direct care occupations do not have federal training requirements, and states' requirements vary widely. Additionally, there are few career ladders or lattices for direct care professionals. These opportunities can help workers transition to different positions within their field to advance their skills and receive increased compensation. As we talk about training for direct care professionals, it's important to emphasize that there is an increasing need for this training to focus on practices that provide culturally competent care, as the nation's population is becoming increasingly diverse. And finally, another challenge is that direct care professionals continue to be undervalued in our society. This under-recognition is despite the vital role direct care professionals play in supporting individuals with daily life. Next slide, please. Another challenge contributing to the workforce shortage is that the nation's workforce programs are often not targeted towards direct care professions. These programs include the nation's apprenticeship program, as well as programs under the Workforce Innovation and Opportunity Act. Often these workforce programs target occupations that are more medicalized or require more credentials than direct care occupations. Additionally, when these programs are available for direct care occupations, it's often associated with insufficient advertisement of the training programs, so people have challenges learning about these opportunities. Next slide, please. And finally, one challenge contributing to the shortage is that there is limited federal and state data on the workforce itself. Direct care job titles are not standardized across federal data sets. This creates challenges for estimating the size of the nation's direct care workforce. Data also do not capture the full size of individuals employed in LTSS. For example, as my colleague Lisa mentioned, there is no federal data on unpaid family caregivers or the gray market. And the limited data that we do have on this workforce is often not disaggregated by direct care profession. This limits policymakers' ability to monitor the workforce and measure the impact of their reforms. Next slide, please. Now let's take a look at the current policy landscape. The direct care workforce shortage is a bipartisan issue. Federal policymakers across the aisle have shown recent interest in addressing the challenge contributing to the shortage. For example, in Congress, key committees have held hearings on the impact of the shortage and opportunities to strengthen the workforce. These committees include the Senate Aging Committee, the Senate Health, Education, Labor, and Pension Committee, and the House Energy and Commerce Committee. Several senators and representatives have also introduced legislation to address these shortages, including bipartisan policies to enhance training requirements, grow the home-based workforce, and improve data collection. Addressing the direct care workforce shortage has also been a priority of the administration. For example, President Biden issued an executive order last year that aimed to enhance support for family caregivers, improve compensation for job quality for direct care professionals, and ensure quality long-term care. This week, the Centers for Medicare and Medicaid Services released a series of rules related to Medicaid LTSS. While today's panel discussion will talk more about some of these recent changes, I wanted to acknowledge the Medicaid Access Rule, which will have impacts on the compensation for direct care professionals delivering Medicaid home and community-based services, otherwise known as HCBS. Specifically, under this final rule, at least 80% of Medicaid payments for specific HCBS must be spent on compensation for direct care professionals. These services include homemaker services, home health aid services, and personal care services. The rule requires that within 6 years, a minimum of 80% of these specific Medicaid HCBS payments be spent on direct care worker compensation. The rule provides a timeline for activities leading up to this requirement, with states having 6 years to ensure that 80% of these payments are spent on compensation for direct care workers. The final rule also allows states to adopt a separate percentage for small providers and apply for hardship exemptions. The rule also includes provisions intended to promote transparency, including payment rate transparency and transparency of the compensation to direct care professionals. The final rule also requires states to establish an advisory group. This group will consult on Medicaid payment rates, and it must include direct care workers, among other key stakeholders. And finally, the rule also requires states to report on a set of nationally standardized quality measures for HCBS. Next slide, please. Now that we've discussed these challenges, what's going on in Capitol Hill and within the administration, we're going to turn to the opportunities for stakeholders to address these challenges. Next slide, please. Let's start off with reforms to create sustainable and supportive environments for direct care professionals. Through the American Rescue Plan Act, many states have adopted innovative strategies to increase compensation. For example, some states have implemented one-time wage increases. Other states developed wage pass-throughs that require employers to give a certain percentage of the Medicaid provider payment rate to direct care professionals' wages. Another option to ensure appropriate and competitive compensation is to ensure Medicaid provider reimbursement rates are adequate. This can be done through market comparisons or increased data collection on payments and workers' compensation. While ensuring appropriate compensation is a necessary step to addressing the shortage, it's insufficient to ensuring support for direct care professionals. It's also important that reforms develop training programs that support the recruitment and retention of direct care professionals. For example, these programs could include a minimum training requirement for workers to receive credentialing, and then provide additional opportunities for the worker through programs specializing in specific populations or services. This would allow the worker to self-direct their training while building upon a standardized foundational training level. When designing these programs, it is important for stakeholders to understand their design options and develop person-centered programs that meet direct care professionals' unique needs. As many states grew these programs from funding from the American Rescue Plan Act, there is an opportunity for stakeholders to develop best practices for creating and operating these workforce training programs. When designing these programs, it's also important for stakeholders to ensure a balance between the benefits of credentialing the workforce and the risks of creating additional barriers for individuals to join the workforce. Next slide, please. There are also several reform options for increasing the number of new direct care professionals. One essential area for reform is strengthening the nation's development programs to improve recruitment and retraining of direct care professionals. Specifically, there is an opportunity to grow and enhance the nation's workforce development programs under key workforce policies, as well as the nation's registered apprenticeship program. These apprenticeship programs combine on-the-job training with classroom instruction. In addition to these programs, stakeholders can also invest in initiatives that raise awareness of direct care occupations. These initiatives should also highlight the essential role direct care professionals play in our society. Another option to recruit new workers is to establish partnerships with community-based organizations that have networks of potential direct care professionals, such as high schools or community colleges. Next slide, please. And finally, to better monitor and understand the workforce and the impacts of any policies on this workforce, reforms should strengthen data collection and reporting. For example, these reforms could include establishing standardized workforce metrics across states and care settings. And finally, there is an opportunity to better estimate the gray market and the number of unpaid caregivers. For example, there could be an enhanced state or federal surveying to better study the trends among these caregivers. Next slide, please. Okay, with this background on the shortage and its contributing challenges, as well as some of these reform opportunities, we're now going to transition over to the panel discussion. I'll pass it over to Stephanie, who will moderate today's discussion. Thank you.
Great, thank you, Allison. And thank you so much for sharing the work of the Bipartisan Policy Center and highlighting some of the challenges and opportunities affecting the direct care workforce. So to offer a description of myself, I am a woman. I have long brown hair. I'm wearing glasses, a red shirt, and a black blazer. So the Direct Care Workforce Strategies Center leverages the strength of national and state partnerships to support systems transformation efforts that in turn support our direct care workforce, family caregivers, states, and people who are supported through direct care. Two of our partners with the center are joining us today for the panel to have a deeper discussion on the direct care workforce challenges, the emerging trends, and the work ahead. So turning to the panel now, we are joined by Tony Gingerelli, the Associate Director of Policy and Advocacy at the National Alliance for Caregiving, and Dr. Kezia Scales, the Vice President of Research and Evaluation at PHI. So Kezia, we're going to come to you first. Lisa and Allison mentioned the challenges associated with data collection during the presentation. How does insufficient direct care workforce data impact the design and the implementation of initiatives meant to support the direct care workforce?
Thank you for the question, and thank you for the opportunity to join this panel today. And thank you to everyone who has registered and is taking some time to be part of this discussion. I just wanted to introduce my on-screen presence as well. I am a white woman with brown, wavy, mid-length hair, brown eyes, and I'm wearing a black and white flowered blouse and a black blazer. So coming back to your question, Stephanie, about data and the challenges associated with insufficient data, I would like to answer that question by starting by reiterating what we do know. We just heard some really important statistics about the size of this workforce and the growth that we've already seen in this workforce to meet demand and the projected growth looking ahead. In the next decade, by 2032, we expect that there will be more new jobs in direct care than in any other occupation in this country across sectors and industries. And we know also a little bit about the profile of this workforce in terms of demographic characteristics, in terms of key socioeconomic indicators like wages, annual earnings, poverty rates, public assistance use, and so forth. And PHI actually shares a lot of these data points through our Workforce Data Center online. But all of those data tell a very high level story about the direct care workforce and the recruitment and retention challenges that we face. We talk all the time, we've already heard it today, about a workforce shortage, but actually we don't even have sufficient details to quantify that workforce shortage. We don't have the data that allows us to actually estimate what is workforce supply in a particular region or local area relative to consumer need for the services that direct care workers provide. So we might know how many direct care workers there are in a given state, but we don't necessarily know where they are in the state or what programs they're serving in or what types of consumers they're supporting, what their skill sets are, and so forth. We don't also know, there are high level national estimates of turnover in this workforce, but we don't have robust data on turnover, retention, job vacancies at the state or much less the local levels. We aren't able to really quantify the stability or instability of this workforce. And again, we don't know a lot about what types of training direct care workers have completed, what their skill sets are, and where the skills or training gaps might be. And we really don't know how any of these indicators vary by differences within the workforce by gender or age or race and ethnicity or other intersecting characteristics. And all of these data points, I would say, are critically needed to be able to describe workforce challenges in any given state, to identify the most promising solutions, and then to evaluate which of those solutions, which of those policy interventions actually make a difference or not, so that we can kind of move ahead and make incremental progress rather than often kind of going around in circles. And so just to close out my answer, we've been doing some interviews as part of the Direct Care Workforce Strategies Center to learn more about direct care workforce data collection across states and where the gaps and opportunities are. And one of our state level experts that we spoke to articulated it really well, I think, and really simply when they said, without better data, there is nothing for us to say, no problems to solve, no recommendations to make.
Thank you, Keisha. We appreciate those insights. So Tony, we're going to come to you now. Last fall, the National Alliance for Caregiving convened 150 caregiver advocates from across the country for your first ever Caregiver National Summit. Can you share some of the key policy recommendations from the summit? And what did we learn about the impact that paid direct care professional workforce shortages, or maybe not shortages, according to what we just heard from Keisha, have on family caregivers?
Sure, I'm happy to, and thank you again for the invitation to speak here today. I thought it would be good to first start with what the National Alliance for Caregiving does, but I also wanted to begin with describing my visual presence. I am a white woman with dark brown hair, wearing a black blazer and a black and white top with red lipstick. So the National Alliance for Caregiving's mission is to build partnerships in research, advocacy, and innovation to make life better for family caregivers through creating systems change. And to start addressing your question specifically on how family caregivers are impacted by the direct care workforce shortage, we know that more and more people across the US are choosing to age in place. And as a result, there is a significantly growing demand for home care services and supports. And due to the shortage of direct care workers as a result of systemic issues and policy, from inadequate compensation and abysmal benefits for direct care workers to limited opportunities for advancement, family caregivers are often forced to take on the responsibilities of care themselves. And I talk to family caregivers and care recipients who are often seeking home care supports, but can't access them. And this lack of support has repercussions. We know from the National Alliance for Caregiving and AARP's report Caregiving in the US that 61% of family caregivers are also balancing full or part-time work while also performing their caregiving responsibilities. And 45% of family caregivers have experienced at least one economic impact as a result of caregiving. So having a lack of support is in part due to the direct care workforce shortage will impact family caregivers' ability to stay in the labor force and achieve financial security as well. Additionally, many family caregivers report physical or emotional strain, and approximately 1 in 4 report difficulty taking care of their own health. And the direct care workforce shortages are leading to more hours of care performed by family caregivers and higher intensity levels of that care. As referenced earlier by Lisa in this presentation, our friends at AARP recently updated their Valuing the Invaluable report, which estimates that family caregivers provide 36 billion hours of unpaid care work worth approximately $600 billion. And this was in 2021. And that's billion with a B. And this work is often invisible and unrecognized. So unrecognized. So it's time that we start recognizing the value family caregivers and direct care workers play in our economy, and address supporting them as two sides of the same coin. And just to touch upon the convening that we brought together 150 caregivers from across the country, we met with legislators on the Hill to talk about the national strategy to support family caregivers, which really is for the first time a national roadmap of how we can better support family caregivers. And it includes within the 5 goals that are outlined in this strategy, better supporting the direct care workforce.
Great, thank you, Tony. And then Kezia, we're going to come back to you now. So how are states using direct care workforce data to improve recruitment and retention strategies? And can you highlight any examples of states on the leading edge of system change in this space?
Sure. Thank you for that question. And I am happy to keep championing the need for and the use of data to inform policymaking in this area. I do, though, want to explicitly acknowledge that collecting data, leveraging data for policymaking around the direct care workforce is not an easy task. This field that employs direct care workers, the long-term services and supports field, is exceedingly complex and fragmented and dispersed. So we know that services are provided across a range of employers and programs and payer types and service delivery models. And Lisa spoke to this at the beginning. Direct care workers themselves are known by an incredible array of job titles in the field, and their roles can vary accordingly. But there is widespread recognition that these challenges, not insignificant challenges, but these challenges must be overcome. We do need to figure out how to move toward more common definitions within and across states in order to be able to collect meaningful and comparable direct care workforce data. And of course, as Allison spoke to earlier, states will be accountable for having this kind of data going forward through the Medicaid access rule. So for example, to be able to evidence what proportion of funding is going through to direct care workers' compensation, and to be able to publicly report when they achieve the 80% threshold, and to be able to also publicly report quality measures and performance measures. So the new rule will add impetus and really underscores the need to learn from and replicate wherever possible what states are already doing, where states are leading the way. So I wanted to highlight 3 kind of areas of practice that we're seeing around data collection and using that data to inform policymaking. First of all is the uptake across a number of states of existing survey instruments, particularly the National Core Indicators State of the Workforce surveys for both IDD, intellectual and developmental disabilities, and for aging and physical, more recently for aging and physical disability services. These surveys generate robust representative data on tenure, turnover, retention, job vacancies, and other key workforce indicators. And what that shows is that states don't have to start from scratch and figuring out which data to collect and how. They can use tried and tested methods in partnership with national experts. And then the second part of the sort of second area of direct care workforce data use are the states that have leveraged or are leveraging their managed care contracts to promote better data collection and evidence-informed workforce development efforts. Here I wanted to lift up Arizona as an example, because Arizona provides a great example of a state that has worked with its managed care plans to come together, to require them and work with them to come together and identify workforce data, collect workforce data, and then make decisions around workforce development accordingly. And a few years ago, PHI was able to partner with the managed care plans in Arizona to field a survey that reached over 4,000 direct care workers. And we learned so much about their training needs, about their supervision experiences, about their job satisfaction, intent to leave, so many indicators that the plans were then able to use to inform their workforce development efforts. And some of that learning also went into the state's American Rescue Plan Act, HCBS spending plan. And then the third area that I just wanted to highlight are the states that have built workforce-specific data indicators into their existing touch points with providers to build out that workforce knowledge, again, to inform policymaking, to inform decision-making here without while minimizing, I guess, the impact on providers who are already pretty overstretched in what they do. So one example there is Texas, which has integrated a number of workforce data points into their cost reports that are required from Medicaid LTSS providers. And the Texas Health and Human Services Commission uses that data to inform their public workforce development strategies.
Great, thank you, Keisha. So, Lisa, we're going to come back to you now. Your publication and research. Would you note any additional considerations for states to inform their efforts to support the direct care workforce? And specifically, are there opportunities to promote a more supportive work environment or to support career pathways, for example?
Sure. Building on what Allison mentioned earlier during the presentation, there's an opportunity for states to tie training programs to career lattices. And there's also an opportunity to help these professionals navigate aspects of their personal lives beyond their immediate job responsibilities. So going back to that first point, what might it look like to tie training to career lattices? Well, the program could start with a foundational training level that, for example, all home health aides enroll in as a state requirement. And the state's training center could then offer continuing education courses for those home health aides seeking to expand their knowledge at more of a post-foundational level. And at that post-foundational level, workers could, for example, specialize in specific populations or care needs, such as gaining certificates in dementia care. Or they could choose to pursue leadership and supervisory training to move toward more management or supervisor positions. Now, I also mentioned the value of providing training and support to workers beyond their job responsibilities earlier. This could include training courses that teach workers how to access healthcare, housing, transportation, financial literacy, or community resources, and other determinants of well-being. And together, these efforts can help meet more of the holistic needs of this workforce and improve job satisfaction and encourage retention.
Great, thank you. Okay, so now we're going to turn to some questions that have been submitted as part of the Q&A. I will turn to both Tony and Kezia for this question for your remarks. As states continue with system change efforts, what best practices or effective models would you highlight for including direct care professionals and paid and unpaid family caregivers in the design and implementation of direct care workforce initiatives? So it seems like this question is really keying in on the importance of engaging those with lived experience and ensuring their voices are empowered to shape and drive the initiatives going forward. So Tony, maybe we can come to you first.
Sure, and that's a really great question. So this happens a lot of times in policy spaces, even outside of the issues we're talking about today, but I will hear time and time again when designing policy or workforce initiatives focused on family caregivers or direct care professionals that we consulted top experts on this topic. My question is always, well, did you include the ultimate experts? Which are the direct care professionals and family caregivers themselves. Their lived experiences are invaluable and they need to be a part of the conversation. I can speak for an initiative that PHI and NAC are working on called the Together in Care initiative that is being supported by the John A. Hartford Foundation, which is focused on really looking at that dyad and intersection of the family caregiver and the direct care worker. But we started out our work on this project with a 3-hour convening of experts to help us flush out our areas of focus. And we opened the session with Debbie, who is a family caregiver, and Zulma, who is a home health care professional, speaking about their experiences and where they saw issues arising in that intersection. And we also invited them to participate in that whole 3-hour convening, if they chose to. And if you have a policy proposal or solution that is focus on both the direct care worker and family caregiver, both of those parties are going to be able to tell you immediately whether or not there are going to be issues arising with the actual actually implementing these policies, in the home in the case of in this case. So it's really essential that their voices are included at the table. And the last piece of this I'll say is, and this goes for both states and organizations, is ensuring that you are compensating family caregivers and direct care workers who are participating in the design and implementation process for their labor. I think that's a big piece of it. If they're taking time out of their day and time out of their busy schedules to do that, it's very important. And, it removes a lot of barriers to being at the table.
Great, thank you, Tony. Kezia, we'll turn to you now.
Sure, I would agree 100% with everything that Tony just said. And I think probably the couple of pieces that I would add are the importance of not just facilitating participation in those practical ways like compensation, which is incredibly important. Also thinking about when meetings are scheduled to allow for different opportunities to participate, but also if it's appropriate and there's opportunity, providing support, coaching, assistance around how to meaningfully show up and participate in those conversations. Joining an advisory board or a work group, particularly if it's a sort of state level group, might be out of a lot of people's experience and comfort zone. And so providing them with the tools, not only to be able to show up, but be able to meaningfully engage and make their voices heard is really important. And then the two other things I would think are, I would suggest are important are having very clear information and processes in place around what are the expectations of participation, what will that participation look like over time, but also what's going to be done at the end of that or on as a result of the participation. So not just kind of having a conversation for the sake of it, but being really clear about what are the next steps and what is the feedback loop so that people who have given their time and their expertise are able to feel like they're part of the dialogue going forward and they know what action has been taken as a result. And then the last thing I would say is just evaluation. Let's come back to the data piece, but just the importance of evaluating how the process goes in order to see whether it actually is playing out as intended or not, and be able to make some course corrections along the way so that that type of engagement is as beneficial for everybody involved as it can be.
Thank you, Kezia. And so let's turn to another question from the Q&A. And this one is also focused a bit on engagement strategies, but it's specifically asking about any states that are engaging in benefit strategy. So housing or stipends or other benefits that could help to improve recruitment and retention efforts. Kezia, can I turn to you for that one?
You can, but mainly my answer is to underscore the importance of the question. It is really very topical. I think a lot of states and other leaders in this work are grappling with how do we build out benefits and supports for direct care workers beyond the essential central wages and health insurance benefits. And I think there is a lot of work to be done to actually figure out how to do that. And I'm really excited about the Direct Care Workforce Strategies Center TA work and the potential there to kind of workshop some of these efforts. So there is a lot of interest. There is a lot of discussion around this. I think there is limited progress in terms of figuring out how to kind of support access to those kind of benefits in a sustainable way for beyond sort of individual employer level initiatives. I would point to Washington State because I always point to Washington State for kind of trying out new ways of working in this field, and they have built in they have a benefits group, and they have built in not only health insurance for home care workers, but also for their dependents, which is a big step forward, as well as retirement benefits and training benefits into what home care workers are able to access in the state. So that's a good example. They even have a shoe allowance in Washington, which I think is such a great example of thinking about what are all of the challenges that this workforce faces. Well, being on your feet all the time, that has an impact on your footwear, and that is a cost. There's a cost associated with that. So and we're seeing a little bit, we've seen a few examples in other states of efforts around housing and childcare, but again, I would just really say it's an area that needs to be, needs a lot of work to develop out.
Thank you so much, Keisha. And it's really exciting to hear that some states are moving in this direction and are exploring initiatives around these benefit structures. So, Tony, I'm going to come back to you. You were just noting some of the training opportunities together in care, for example. Would you note any additional opportunities to really support the relationship between family caregivers and paid direct care professionals, understanding that each of them are such important pieces of the care or support team?
Yeah, absolutely. So something that we're exploring with Together in Care is, again, that relationship between the direct care worker and the family caregiver, but specifically the policy barriers that exist, the research needs, as well as workforce interventions. And this is really focused on elevating that bond of these essential caregivers. Some of the areas that we're exploring are promoting care integration, so better integrating direct care workers and family caregivers into care teams. Expanding access to self-direction. So that's policies that empower individuals and their families to have greater decision-making over their care, and in the same spirit, making sure self-direction programs are better resourced and more accessible. This is often through Medicaid. Strengthening matching service registries. So that's developing more online platforms that connect individuals and their families with paid caregivers, so we can foster stronger relationships and ultimately better care outcomes. And the last piece is investing in research. We know that knowledge is power, and by investing in more research on the dynamics between the direct care workers and family caregivers, we can develop targeted interventions and policies. So we're working on finalizing this report with policy recommendations and opportunities for future research in this area. So that's something to look out for. I also think that we mentioned, not to plug the Direct Care Workers Strategies Center again, really great opportunities with technical assistance, as well as peer learning collaboratives. And then the last piece, and I'll kind of throw it back to Keezy on this, is I know PHI has been working on a pilot program specifically focused on training family caregivers on how to interact with direct care workers, and direct care workers how to interact with family caregivers, to make sure there's common language and common understanding across the two groups for better care outcomes. So I don't want to speak on behalf of that, but I think it's a really amazing initiative that they're piloting.
Can I speak to that just very quickly, Stephanie? Thank you, Tony, for raising that. I think it's just sort of reflective of the need to tackle these challenges from every direction, including from a sort of more top-down policy approach and from more of a grassroots, practical, practice-based approach. And so in addition to partnering with NAC on the Together in Care initiative, we are partnering with Florida State University on this Partnering to Improve Care training program, which Tony described beautifully. And we have pilot tested so far with a small group with really great response, and are excited to be taking it to the next level and learning more about the most effective ways to reach family caregivers and direct care workers together, and to strengthen the relationship between them.
Well, there are certainly a lot of exciting opportunities to look forward to, and I'm noticing we are nearing the end of our time together today with the webinar. So I'd like to turn to each of our panelists for last impressions or any additional recommendations that you would note. Keisha, we'll come to you first, and then to Tony, and then finally, we will ask Lisa to summarize key messages from the webinar today.
Thank you. Thank you again for the opportunity to be part of this conversation. What I would like to leave on is just the incredible momentum that I think we have right now to address the workforce shortage, which is real despite the lack of data to quantify it, and the recruitment and retention and job quality challenges that we face across long-term services and support settings. We have we have recent executive orders and hearings and legislation and rules and the Direct Care Workforce Strategies Center and all that will offer. There's so much happening now, and it's such a widespread effort involving a lot of different partners so that's the opportunity. That's what's exciting. And it is also the recommendation that we just keep up with this momentum. This is the moment. We have these opportunities, and we have a lot of learning from the last few years, and we have to harness all of that and pull forward together in a direction that leads us to more transformational change than we have seen up until this point.
Thank you, Keisha. Tony, over to you.
Sure. So there's two things that I'd like to end on. First is reemphasizing Keezy's approach. This really is going to take a multifaceted approach to address the issues that we're seeing in terms of the shortage for direct care workers, from policies to programs and research. I would also say to make sure that family caregivers are not forgotten in this conversation. Again, I see this issue really as different sides of the same coin. And the last piece that I want to end on is there really is no time to wait to start supporting solutions and investing in research to address the direct care workforce shortage and supporting family caregivers. They play an essential role in our healthcare system, our economy, and society as a whole. They care for us and our loved ones every day, and it's time we care for them.
And I'll echo everything the other panelists have said. And I'll add that Americans are feeling the impacts of not having enough direct care professionals, and the time for action is now. Federal and state action are both needed to address this long-standing, deeply rooted challenges to recruiting and retaining direct care professionals. There is no single solution that will fix this workforce shortage, but progress is possible with a range of reforms that focus on creating supportive environments that value these professionals, as well as unpaid caregivers who play a critical role in alleviating the demand for paid direct care professionals. And I'll note that competitive compensation is an important part of supporting these workers. These are challenging jobs, and wages have been relatively stagnant. Many individuals leave these direct care roles for fast food roles that may provide higher pay with less burnout. So that's part of ensuring a supportive environment for these workers, and exploring opportunities to tie increased training and experience to increased wages is an important consideration for states looking to create a comprehensive strategy to support these workers. And next, it's important to think about leveraging domestic workforce programs to increase the number of direct care professionals, and also to improve data collection on the workforce so that we can start measuring the impacts of all of these efforts over time. And to end on a bit of a positive note, I do want to underscore that this is a bipartisan issue. And the ongoing interest and efforts that we're seeing at the federal and state levels suggest that policymakers do want to address this issue. So looking ahead, I am hopeful that we can make some progress forward to support the direct care workforce.
Great. Thank you, Lisa. And I'd like to take the opportunity to say thank you to our panelists and presenters today, and to all of you for joining us.
I wanted to take the time again to echo Stephanie. Thank you all to our panelists. This concludes today's webinar. Please contact Direct Care Workforce at NCOA with any questions. Thank you so much and have a great day.